Welcome again. So, in the last lecture I briefly introduced you to what we call organic brain disorders or organic mental disorders, and in this lecture I will talk to you about something which you would have heard the word in common parlance, and this is often said that, and there is a lot of myth around it also. People are having schizophrenic mind, or we are in a schizophrenic state. So, what does this schizophrenia means? Now, whatever people mean when they are talking about schizophrenia and socio-cultural and cognitive language, probably most people mean it is a split personality. That is the common myth. But yeah, the way it was understood previously, it has given an impression that it is a split personality, that people live in two personalities at different times, but it is much more than that. It is actually one of the most serious psychiatric illness, and obviously over last more than 100 years since it was defined and discovered, it has changed its course and the way it has presented. So, we will just try to, in the next half an hour, we will try to delve into what schizophrenia is all about. It is a major psychiatric disorder and it affects 1% of population all across the world. The hallmark is there is a distortion of thinking and perception, is often out of sync with mood. Often, I mean, it is not necessarily in the mood, and the thought can be in sync at times in schizophrenia, but in most of the schizophrenic patients, all three are more or less affected: the thought, the perception and the mood. The normal personality and intellect may exist with the symptoms, as in paranoid schizophrenia, or the symptoms may totally overpower the normal personality, as in say a hebephrenic schizophrenic or undifferentiated. Do not get bothered about these two heavy words, but they are just the type of schizophrenia which we classify. But just to make you understand, the paranoid schizophrenic patient may have schizophrenia and still present you as a very, very well preserved person, whereas a disorganized schizophrenia or a person with undifferentiated may really present you with lot of total disorganized, disturbed behavior, which is not very difficult to notice. The hallmark is one of the two major psychotic illnesses: psychosis, as you will remember from the previous lectures, loss of touch with reality, lack of insight, presence of delusions and hallucination. So, delusion falls into thought and hallucination into perception. So, what are the symptoms? How do you know? The common symptoms, which are more or less very robust, are hallucinations, which can happen in any modality. The commonest are in auditory, like from the ear, first person, second person or third person. It can be, it's like somebody talking directly to the person. First person is very rare, me talking to myself, does not happen normally, but can't be ruled out. Second person is some voices are telling me something to do, criticizing me, but directly mentioning like you. The third person hallucination are 2 or 3 voices discussing me, the extension of which is running commentary, like voices are actually, when I am doing something, they are giving a commentary. Delusions, as I said, this is a disturbance in perception. Delusion is a disturbance in thought. Formal thought disorder we discussed, like breaking up of the link between the thoughts, the loosening of association, there is no coherence in the thought. Thought phenomena, like sometimes the patient feel that somebody is inserting thoughts against their will in the thought, or somebody is withdrawing the thought against their will, or their thoughts are being broadcasted. Somatic passivity is the feelings which they undergo are controlled by some external event or external object. Whatever they are doing is being controlled by something else. So, these form a group of positive psychotic symptoms, like something new is coming up. Whereas, in negative symptoms, there is avolition, there is no will to do anything, apathy, not interested in objects outside, not willing to talk. Alogia is poverty of content or poverty of speech. The whole verbal output may be less, or even if they are speaking, there may be no significant content in that, and amotivation. Now, all these symptoms barring alogia, a little bit here and there, everybody knows what they mean, but in schizophrenia that becomes a mental state which is almost continuous or worsening. Onset of schizophrenia is between 16 to 45 years of age largely. People can have late onset schizophrenia, by the time schizophrenia like symptoms can appear, as we discovered, because of the organic reasons or because of some other etiology. There is no difference in, and whereas onset before 16 is we call early onset schizophrenia. If you remember from the previous lectures, we talked about that the brain overgrows in the initial years, and there is a pruning of neurons and synapses which starts. This age almost corresponds to that. In fact, one of the theories which we will discuss later is associated and has been linked to this pruning which starts. There is no difference in male or female, and early onset is more disorganized. So, let us briefly look at the history. This Emil Kraepelin was the first person who called it dementia precox. It develops early in life and course deteriorates, chronic, but was not followed by any organic changes. Blauler renamed the dementia precox as schizophrenia in 1911, and he was the person who actually gave the concept of splitting of mind. Kurt Schneider actually organized it better, and the role of psychotic symptoms is hallucination, delusions, and gave them the privilege of what he called Schneiderian first rank symptoms. Now, the symptoms which I talked about previously are the first rank symptoms. So, they formulate the concept of that the experiential mental state which the patient is undergoing. So, they can be, it used to be run a very continuous progressively declining course say 50 years back, but with medication or maybe with a spontaneous change in course, what we see now that schizophrenia is showing some better course, like it is continuous, it could be continuous without temporary improvement, it could be episodic with progressive or stable deficit. So, there are episodes which happen, and then with every episode there are some deficits which appear, and then more or less it goes on like that. Or it could be episodic with complete remission. There could be episodic schizophrenia, the person improves and he can keep having many episodes in the life. So, but more or less schizophrenia has a continuous course. Now, these, if you look at the stages, not everybody has these stages, but there are people who have prodromal, like small soft symptoms which are going on for months to years. There is an active phase of either positive or negative symptoms, which more or less it stabilizes within 4 or 5 years, and then the person remains in a residual phase for the rest of their life. This is the type of course which we have seen evolving over time, but with medication a lot of things have changed. So, ICD-10 has international classification of disease, and we said DSM-4, now DSM-5 is there. This is according to ICD-10. The negative symptoms are represented by cognitive disorder, having its origin in the disorders of association of thought, as I mentioned, with emotional blunting. The positive symptoms are characterized by the presence of hallucinations and delusions, we have talked about it. The division is not quite strict, and there can be a great mix of symptoms. So, obviously, the patient has not read the book. So, when the person comes and they will not be acting according to the book and creating those symptoms. What normally happens is a huge mix and overlap of symptom. This is the diagnosis according to the classificatory system ICD. You see schizophrenia is the F20 chapter 5 of ICD-10, And these are types, like we said, paranoid, hebephrenic, catatonic, undifferentiated. There is something called post schizophrenic depression, residual. This is the third phase which we talked about, the prodromal, active and residual. Simple schizophrenia, which is very difficult to diagnose, and unspecified. Now, there are other syndromes which almost are at fringe or related to schizophrenia, like schizotypal disorder, something called a delusional disorder, or acute and transient psychotic disorder. We will just discuss it briefly as we move on. Schizoaffective disorder, we have not talked about mood disorder till now, but when we will talk about it later, what will you see, there is a group of disorder which have the presence of both the schizophrenic symptoms and depressive symptoms. Obviously, there are criteria to diagnose schizophrenic disorder, manic type or depressive type, but largely it is a, because now that is the dilemma of understanding the cause. Now, dilemma is whether schizophrenia is a different illness and mood disorder are different illness. That is what it is understood. Schizophrenia is a disorder of thought and perception with some mood disorder, whereas in mood disorder, where mania and depression are diagnosed, are essentially a disturbance of mood. But there is a small group of patients who have both symptoms. So, they normally fit in the schizoaffective disorder, where in the absence of mood disorder, the schizophrenic symptom should be present. That is one of the basic criteria. For a substantial period of time, in the absence of mood disorder, if the psychotic symptoms continue, you call it schizoaffective. Delusional disorder is where normally there is, if you recall the definition of delusion, it is a false fixed morbid belief. Whether they are related to schizophrenia or an independent disorder, we still do not know through the cause, but for functional classificatory purpose, it is understood as a part of this psychosis. The only symptom there is what you call a delusion. The person may be functioning normally in other areas of life, have a normal mood, not having any perceptual problem, having insight and judgment in other things, but where it comes to this false fixed belief, that is one of the major occupation of the mind. If I give you an example, there is something used to be called what is called monosymptomatic hypochondriacal psychosis. There are a lot of old people who will come and tell you that I always feel there are ants or small organisms which are crawling under my skin. Now, there is no proof for that. Obviously, they cannot crawl, they cannot be, this is not a biological possibility, but they are firm in that. Or there may be a person who has a firm belief that about suspicion about somebody, that this person is planting something against me. Now, these delusions, the most common is something called delusion of infidelity, where a spouse may be suspecting of the other person of having some affair and being infidel. In delusion of persecution, people feel that somebody is plotting against them. Now, if they have hallucinations and other behavioral disorganizations along with it, then probably it is not a delusional disorder, but they can maintain this delusion and keep moving in life as they go along. There is another thing called acute psychotic disorder. So, if suddenly somebody gets psychotic within 2 weeks and typical fleeting symptoms, polymorphic symptoms what you call, but these schizophrenic symptoms, like in schizophrenia, they are more or less persistent and go beyond 1 month or few weeks. It used to be 6 months before that, but now the criteria is 1 month. If it is less than that and it is not as well systematized, elaborate symptoms, like for example delusion. Now, this is one hallmark. When people are having acute psychosis, the symptoms are more fleeting. They are schizophrenia like, or they may be typical schizophrenic symptoms, but the recovery usually occurs within a few months, and it may or may not be associated with stress, although stress can precipitate schizophrenia also. But if the symptoms have begun within 1 or 2 weeks, it is normally acute psychosis. Symptoms are polymorphic, they are typical, but they are quickly changing at times. Whereas in schizophrenia, if you look at delusion, the delusional disorder, when people are having delusion, the delusion is very well systematized and very elaborate, and over years the person would have built a whole logic of this delusion. So, it is like a whole thought process and a story of that delusion which goes on into the head when it comes to delusion. In schizophrenia of short duration, it may not be that well elaborate or well systematized, but still it would have been persisting for months along with other disturbances. So, it is a sometimes it is a fine distinction, and the lot of mental status examination and interactions over a lot of sessions are required, but largely they form a group of psychotic symptoms. The induced delusional disorder is a rare thing where one person is suffering in a family and the other person also starts believing. Schizoaffective disorder, as I said, the episodic disorder in with both affective and schizophrenic symptoms are prominent, but you can't say it is schizophrenia and neither can you say it is depressive or manic episode. They have periodic schizoaffective disorder with manic symptoms, and normally they remit fully. So, what causes schizophrenia? The most common theory, there used to be a lot of psychological theory of having a cold schizophrenogenic mother, where the mother was emotionally blunt and not attached to the child. So, this was one of the psychological theories of it. There is another social drift theory that because of the people living in poor socio-economic strata predisposes them to developing schizophrenia like symptoms, but a lot of this multifactorial causation is established now, not one thing, because even when you talk about genetics, we all know monozygotic twins which come from the same embryo and dizygotic where there are two embryos. There is a high concordance rate when you study people with so the genetic studies normally have been done either by the adoption studies, like kids from the family where there is a history of any illness have been adopted into other family and have developed illnesses, or twin studies. 100% concordance is not found in twin studies. So, even if you find 60-70% monozygotic twins having, if one has the other also has, ideally they should have because they share the same set of genes. If they were 100 out of 100 monozygotic twins developed schizophrenia, if one has the other also has, then total genetic inheritance can be considered, but it is not so. So, where does the 30% come from? And now with the genetic and epigenetic debate more or less settling down, it is understood that you may have a propensity or vulnerability to develop schizophrenia. You have the genes, and with the adequate amount of stress, it gets precipitated, which is the current understanding how the. So, there are a lot of gene candidate, but we still have not found the real one gene which is. So, probably it is a polygenic thing, multiple genes. So, it is caused by interaction of external and genetic factors, very often polygenically. So, the relative risk for schizophrenia is around 1% for normal population. So, all of us, me, you, everybody has a risk of developing 1%, and that is because, and do not get surprised by it, because we all share the common genetic pool, at least the modern man over a lakh of years or 2 lakh of years or maybe less than that, and with the migration genetics telling us that we all come from a single family or single mother in Africa, the genetic pool is the same. So, as the genes for color of eyes, skin, hair, height all have come down in us. So, the genes of illnesses have also come down. So, that gives us that 1% risk for normal population. It increases to 5.6 or 5 to 6% if the parents have it, almost 10% if the sibling have it, and almost 12 or 13 for the children of a person who has schizophrenia. So, as I said, the etiology and the pathogenesis is not known. It is accepted as a group, whether all schizophrenia are the same and we are calling them paranoid, undifferentiated, hebephrenic, disorganized, because we try to look at the collection of symptoms in a different way, or there are different schizophrenias is still a debate. So, internal factor, as I said, genetic, inborn, biochemical. The external factors are trauma, infection of CNS, stress. Now, these factors modulate the genetics. So, you do not develop schizophrenia if your genes, if you do not have schizophrenia in you. The external stress when you are old can trigger, but you will, because if external factors are causing, then everybody who undergoes say a trauma or say a tumor will develop schizophrenia. But then that is not schizophrenia, that is maybe schizophrenia like symptoms which we talk in the organic thing because of a factor. With the stress you may have a schizophrenia like symptom which may go off in 2-3 weeks, that is acute psychosis. But when the genes are modulated with these external epigenetic factors, that may be the trigger of schizophrenia. So, whether we know the cause or we do not know, what we have definitely found out to large extent is the disturbance in the neurotransmission. This is largely the most influential and plausible is based on the disorder of neurotransmission. What we found out, which is in a reverse order actually, it is a reverse learning which went through. When we found out that there are group of drugs which block dopamine, the action of dopamine, if you remember I showed you the dopamine pathways in the brain in certain areas, those areas we have learned over time with imaging and rest of the biochemical studies. But what we found out that the drug which blocks dopamine improves the schizophrenic symptoms, and the drugs, some of them are of drug of abuse like dopamine releasing drugs, amphetamine, mescaline, LSD, they increase the dopamine level and they almost induce state closely resembling paranoid schizophrenia. So, this is a two-way learning which went on. One, the drugs which are blocking dopamine improved, and the drugs which increase dopamine, which are drug of abuse, create symptoms like LSD creates a hallucinatory state. So, the classical dopamine hypothesis, which is actually the guiding principle of all the treatments which have developed till now, is basically you give drugs to block dopamine. Block dopamine in certain areas, block the receptors of it, which in turn through a feedback mechanism decreases the dopamine. So, are related to dopaminergic hyperactivity in the brain. So, the hyperactivity during schizophrenia is a result of increased sensitivity and density of dopamine D2 and other receptors. There are a lot of receptors, we just label them D2 and D3 and D4. So, dopamine, if you understand broadly, is the increased levels of dopamine causes psychotic symptoms, and we treat them by decreasing dopamine or blocking the receptors. So, the other models are various other neurotransmitters over time have been implicated now, norepinephrine, serotonergic, excitatory, glutamatergic, if you remember we talked about. Now, these have been implicated as more refinement of development of medicines has gone in, especially with the atypical antipsychotics, which I will tell you. The other models which talk about that it may be a possibility of disorder of cognition, neurocognitive disorder, where we look at the whole disturbance, the large scale disturbance in the network, the large scale disturbance in the way information is taken into the mind of the schizophrenic patient and integrated, and the decisions on action or emotion is taken. So, they may arise from a cognitive dysmetria like Nancy Anderson says, or a neurodevelopmental. We talked about the neurodevelopmental thing previously, when we are talking about that the brain actually is overgrowing and there is a synaptic pruning, and that is the time when schizophrenia triggers. That the presence of silent lesion in the brain, mostly important for the development of integration of information. genetic, inborn infection, this can affect all this during very early development. So, it is possible that when the brain is developing in the first 2 years of life or in the womb, there maybe mother has undergone an infection, or maybe as simple thing as a mother being in stress. This is the basis of when we talk of well-being clinics, that mother during pregnancy should be stress free, because all that stress and the subsequent disturbance in cortisol and other hormones, it really plays a epigenetic effect on the genes, and which triggers off schizophrenia in a later age, because it affects the way synapses are formed, it affects the way the network is being integrated, and when the synaptic pruning starts and the neurons are removed or the synapses are removed, it actually triggers off a deficit in certain area. So, it does not interfere too much with the basic brain functioning, but expresses itself at the time when the subject is stressed by demands of growing needs for integration during formative years. So, this is one of the most comprehensive and most possible theories of schizophrenia. Now, that it all can be integrated. So, you get exposed to trauma, toxins, infection, or some epigenetic thing which can uncover the gene of schizophrenia, not one single gene, maybe it is a polygenic inheritance. So, a lot of genes can get triggered off. So, as you are growing, the brain already is overgrowing at that time like a normal process, but the formations which are happening may be getting affected by these epigenetic factors. And when the brain starts pruning, it does not go on, the network does not remain like the other person who is not having a schizophrenia. There is more deficit which arises in certain areas, like the imaging has found out, imaging and EEG have found out definite or evoked potential, they have found definite changes in schizophrenic, the patients with schizophrenia, right in the central executive network, like in insula, like in anterior cingulate gyrus, the networks which take the information from outside and integrate, and the processing of information is different. A lot of these patients with schizophrenia, especially in say hallucinations, they keep responding to the internally generated image which are normally suppressed in a normal person. Like your mind may be generating a image, and at the same time external stimulus is also going, forming an image in the brain which responds to the external stimulus. So, what is important for survival is that you respond to the external image. So, the thinking brain, the central executive network, or the higher center what you call, or the salience network, takes out features from both the internal image as well as the external image. Now, the emotional centers will decide which is important, and normally naturally they will decide, so that you keep in connect with the external thing, it will be suppressed, the internal image, but this mechanism fails in schizophrenia. So, there may be a deficit in the central executive network's connection with the areas which are sending image to it. So, the brain is not reading what is internal and what is external, and internal image overpowers the external image, leading to hallucination. So, this deficiency network is because of probably the epigenetic damage which has happened, and some neurons or some part of the network may be missing. So, broadly this is what, so I will briefly tell you about the treatment. The mainstay of treatment is called antipsychotic. Drugs are the mainstay of treatment. So, these are just the name of the drug, you do not have to really go into it. This group is called atypical and this is called typical. Just to sum up, the treatment of choice in schizophrenia is medication, and it takes a long time, it may continue from months to years. The earlier the treatment started, the faster it is stopped. Within, if the illness goes beyond 6 months, the treatment can go on for very long, and once the person improves, rehabilitation is important and the person has to be returned back to normal life. There in clinical psychology and rehabilitation steps in, they can lead a normal life. John Nash even won a Nobel Prize with paranoid schizophrenia. Thank you, and in the next lecture we will talk about mood disorder, something which you have already heard. Thanks.